everyone. On this podcast, we're going to talk about the evidence on Pitocin during the third stage of labor. Hi everyone, today is a special day, and it is a day that we are going to release this podcast all about the evidence on Pitocin during the third stage of labor. This is a topic that has been requested by our audience for many years, and we are so thrilled that we're able to provide this research evidence to you and make it publicly available. So let's dive in. Since this is a bit of a longer podcast, I thought I would give you an outline before I get started. We're going to start by going over some definitions first, and then we'll talk about the three different types of management of the third stage: active, expectant, and mixed. We'll then talk about the history of how the third stage of labor has been managed over time. We'll talk about how oxytocin works in the body and how it differs from synthetic oxytocin. We'll discuss the new definition of postpartum hemorrhage and talk about the causes of postpartum hemorrhage, how it's measured, and whether or not rates of postpartum hemorrhage have been increasing around the world. We'll then move on to the research evidence on active management of the third stage, expectant management, and mixed management. After I go over the evidence, I'll move into the evidence on best practices for which type of management you choose. I'll then go over research guidelines from around the world and give our conclusions, and we'll end with the bottom line. The third stage of labor, or the placental stage, begins after the baby is born and ends after the birth of the placenta, sometimes called the afterbirth. It follows the first two stages of labor, which you can think of as stage 1, which is the dilation or opening stage, and stage 2, which is the pushing the baby out stage. In practice, there are three main approaches to birthing the placenta during the third stage. One approach is expectant management. This is also called physiological, conservative, passive, watchful waiting, or hands-off management. This approach is popular in some European countries, New Zealand, and in midwife-led births in the United Kingdom, Ireland, and the United States. With expectant management, the care provider waits while the birthing person's uterus continues to contract after the baby is born. These contractions cause the placenta to gradually separate from the uterus, and then the placenta is pushed out or birthed with the aid of gravity. With this approach, care providers do not give Pitocin, which is a synthetic form of the hormone oxytocin. They also do not give any other medications that cause the uterus to contract to prevent heavy bleeding before it occurs. Instead, they closely monitor the mother after birth, and they treat excess bleeding with medication if it occurs. Some providers who are skilled at expectant management will take actions to support the mother's natural release of oxytocin. For example, through immediate skin-to-skin contact, encouraging opportunities for breastfeeding or chest feeding or any other form of nipple stimulation, and ensuring a warm, calm, private birth environment. With expectant management, care providers do not clamp or cut the umbilical cord until the placenta is birthed, or at least until the cord has stopped pulsating or has gone white. Care providers also do not use traction or gentle pulling on the umbilical cord, although some providers may use gentle traction once the placenta is visible in the vagina and it's ready to be birthed. A second approach is called active management. This is also called hands-on management, when the provider uses different interventions to try to prevent severe blood loss after birth, known as postpartum hemorrhage. This management approach came about in an attempt to reduce the rates of postpartum hemorrhage, which is the leading cause of maternal deaths in countries defined as low income by the World Bank, and it accounts for more than a quarter of all maternal deaths globally. The U.S. Centers for Disease Control estimates that postpartum hemorrhage accounts for about 11% of all pregnancy-related deaths in the United States. Surveys from the United States and from the United Kingdom have found that physicians are much more likely than midwives to always or usually use active management. With the traditional use of active management, care providers give Pitocin, or another drug that contracts the uterus, just before, with, or after the birth of the baby to help the uterus contract. Care providers clamp the umbilical cord early, before the cord has stopped pulsating. And care providers use gentle, controlled traction on the umbilical cord with counter pressure on the uterus to aid the birth of the placenta. A third type of management of the third stage is called mixed management. This is sometimes called combined management. It's a mixture of some of the components from expectant management and some of those from active management. There are many different variations of mixed management, But one example might include giving Pitocin with the birth of the baby, waiting to clamp the umbilical cord until it has stopped pulsating, and remaining hands-off as the mother births the placenta with the aid of gravity. As we go further into this podcast, it's important to understand that while the traditional definition of active management is a package of 3 specific components: 1, giving a medication such as Pitocin, 2, early cord clamping, and 3, controlled cord traction, more modern definitions of active management focus mostly on giving the uterotonic, the Pitocin, and could be described truly as mixed management. In other words, routine early cord clamping and controlled cord traction are no longer considered essential components of active management. For the rest of this podcast, we'll refer to the body's own naturally produced endogenous oxytocin as oxytocin, and we'll refer to synthetic oxytocin as Pitocin. One small qualitative study found that women are usually given little or no information from their care providers about their options for birthing the placenta. When care providers did offer information, it tended to reflect their own preferences or usual practice style, rather than truly discussing the options. This is concerning to us because birthing people express diverse preferences for the 3rd stage. Some consider expectant management an essential element of natural or physiologic birth, while others consider active management to be the, quote, safe route that prevents complications and helps you avoid further interventions. So in this podcast and in our signature article available at evidencebasebirth.com/3rd stage, we're going to ask and answer these questions. Who is at lower risk for severe bleeding after birth and who is at higher risk? What's the evidence for expectant versus active or mixed management? And what are the potential benefits and risks of each approach? But first, let's talk about how has care during the 3rd stage of labor changed over time. I always love looking at the history of different birth practices to figure out how we got to where we are today. Well, historically, the focus was on treating postpartum hemorrhage when it occurred, not intervening in an attempt to prevent postpartum hemorrhage. Midwives in ancient times treated postpartum hemorrhage after the fact, after it happened, with vaginal packing or applying hot vaginal douches with limited success. The first actually effective treatment for postpartum hemorrhage came into use around the 1500s. Midwives discovered that extracts of ergot, a fungus, could cause the uterus to contract and stop bleeding excessively. So if a mother appeared to be losing too much blood after birth, the mother would be given extracts of ergot as a, quote, labor tea to stop the bleeding. Since ergot worked by causing the uterine muscles to contract, it was the first drug used to treat postpartum hemorrhage. It was the first uterotonic drug. And uterotonic is the word we use to describe medications that make the uterus contract. Oliver Prescott was a physician in Massachusetts. He published an official dissertation on the use of ergot to treat postpartum hemorrhage in 1813. About 100 years later, in 1912, Dr. Barry Hart of Edinburgh made the case that ergot should be used before postpartum hemorrhage occurs as a way to prevent excess bleeding. In other words, he proposed active management of the 3rd stage of labor by giving mothers a uterotonic drug to prevent postpartum hemorrhage. This idea caught on, especially in the 1950s, after studies found a reduction in postpartum hemorrhage with the routine use of ergot injections in the 3rd stage of labor. Still today, the World Health Organization recommends ergot preparations as one of the effective uterotonic drugs for people. However, it is not recommended to be given to people with high blood pressure disorders because raising the blood pressure can be one of its side effects. So ergot was that first uterotonic drug used to treat postpartum hemorrhage. Synthetic oxytocin, which is known by the brand name of Pitocin in some countries and syntocinon in other countries, first came into use in the 1950s, much later than ergot. Soon after, in the 1960s, active management, where they gave the uterotonic drug, plus immediately clamped the cord and used controlled cord traction, became popular in many hospitals to try and prevent postpartum hemorrhage. Backing up just a little bit, the hormone oxytocin was discovered in 1906 when Sir Henry Dale of London found that an extract from the human pituitary gland caused uterine contractions in a pregnant cat. He named the hormone oxytocin after the Greek words for, quote, quick birth. So that's literally what oxytocin means. Then in 1953, a New York biochemist published the chemical structure of oxytocin, for which they received the 1955 Nobel Prize in Chemistry. Research on oxytocin in the early 1950s used extracts from cow and pig pituitary glands. However, today, commercially sold oxytocin is prepared synthetically in laboratories. So today, Pitocin, that synthetic form of oxytocin, is an extremely commonly used drug in clinical practice to start or induce labor, as well as to speed up or augment labor. It's also used to help the uterus contract after birth in the active management. There are a few other uterotonics that can be used for postpartum hemorrhage, but in this evidence-based birth podcast and signature article, we're focusing on synthetic oxytocin or Pitocin as the uterotonic in the third stage. So to understand why these drugs are used in the third stage of labor, it helps to understand more about how oxytocin works in the body. In 2019, Uvnas Moberg et al. Published a systematic review of 20 studies that measured oxytocin levels at different points during pregnancy and labor and childbirth. They found that during pregnancy, blood levels of oxytocin gradually rise, increasing 3 to 4-fold. Levels of oxytocin rise even more in labor, when pulses of the hormone become larger and more frequent to contract the uterus and help the progress of labor. The maximal frequency of pulses was found to be 3 pulses per 10 minutes, which is not tied to the frequency of contractions, just before the birth of the baby. There is a large pulse of oxytocin released from your body during the actual birth when the baby's head emerges, and pulses continue during the third phase of labor with the birth of the placenta. The presence of either your own oxytocin or a synthetic Pitocin is critical to preventing postpartum hemorrhage in the third stage of labor. After birth, oxytocin or Pitocin continues to cause the uterus to contract to expel the placenta. With each contraction, the movement shears the placenta from the uterine wall. There's an upward wave of separation that causes the upper part of the placenta to detach last. When the placenta detaches from the side of the uterine wall, this leaves a placenta-sized wound on the inside of the uterus. The mother's oxytocin, or the Pitocin, continues to cause contractions, which causes the uterus to sort of clamp down with pressure on the bleeding blood vessels where the placenta used to be attached. It helps stop the bleeding at that wound site to help prevent postpartum hemorrhage. Now, oxytocin and Pitocin are identical in chemical structure, which is composed of a chain of 9 amino acids. However, oxytocin and Pitocin don't act on the body in the same way. In addition to causing uterine contractions that help birth the placenta and prevent postpartum hemorrhage, the mother's own oxytocin is also released in the brain, where it reduces anxiety, stress, and pain. This is one of the major differences between oxytocin and Pitocin. The mother's own oxytocin levels rise in both blood and brain fluid, but Pitocin does not cross the brain because of the blood-brain barrier. Another difference between oxytocin and Pitocin is that when Pitocin is given during labor, it can cause more frequent, longer, and more painful contractions. That's usually because it's given at higher doses compared to the body's own usual pulses of oxytocin. Oxytocin in the body, as well as Pitocin, both cause the uterus to contract by binding with oxytocin receptors on the cell surfaces of the uterus. When there's a lot of oxytocin, the body kind of compensates by decreasing the number of receptors in an effort to protect itself against overstimulation. This means that prolonged exposure to synthetic Pitocin in labor may lead to a reduction in the number of oxytocin receptors. This is a process called receptor desensitization. This is less likely to happen in physiologic labor and birth when your body's own oxytocin is used, because your own endogenous oxytocin is released in pulses and then rapidly broken down by an enzyme. So there's very little, if any, oxytocin left in your bloodstream between the pulses. Getting that break from oxytocin exposure protects against receptor desensitization and helps keep contractions effective. So next, let's move on to talk about what is postpartum hemorrhage. Postpartum hemorrhage, often abbreviated PPH, is defined as excessive bleeding after birth. When it occurs in the first 24 hours after birth, it's sometimes called primary or early PPH. And we're going to focus on that early or primary PPH. It can be helpful to remember the 4 T's that cause postpartum hemorrhage. tone, trauma, tissue, and thrombin. Let's start with tone. Loss of muscle tone in the uterine muscle is also called uterine atony. Atony literally means without tone. Uterine atony is a serious condition responsible for most postpartum hemorrhages, about 70 to 80%. Since it's the most common cause of PPH, care providers usually suspect it first before other possible causes. The reason Pitocin is given during the third stage of labor in active management is to help the uterus contract so that the bleeding will stop even if the mother's uterus lacks tone. Having your labor induced with Pitocin or prolonged use of Pitocin for augmentation during labor are considered risk factors for uterine atony. This is because Pitocin can cause more frequent, longer, and stronger contractions than the body's own natural pulses of oxytocin, which increases the risk of uterine muscle exhaustion and atony. Labors that are very prolonged or rapid with very strong contractions can also lead to uterine atony. Other factors that can decrease tone in the uterus besides just exhaustion of the muscles include infection, having a large uterus, having an unusually shaped uterus, or taking drugs that relax the uterus to prevent preterm labor. The second T that can cause PPH is trauma. Trauma such as uterine rupture, tears to the cervix, vagina, or perineum, or episiotomies can also cause postpartum hemorrhage. The tears must be repaired in order to stop the bleeding. Pitocin after birth with active management does not directly reduce blood loss caused by tissue trauma because the tears must be repaired to stop the bleeding, but it reduces overall blood loss, which could become more beneficial if somebody is losing blood from trauma. The third T is tissue. When portions of the placenta or the membranes are left behind in the uterus, they can prevent adequate contractions and contribute to PPH. The tissue must be removed to stop the bleeding. Having disorders of the placenta can also put the mother at increased risk for leaving tissue behind. For example, placenta accreta is a serious condition where the placenta grows too deeply into the uterine wall, typically due to scarring from a prior cesarean. The fourth and final T is from thrombin. The T for thrombin reminds care providers to evaluate if the mother is able to clot normally. If not, treatment may be required to help with blood clotting. This is thought to be the least common cause of PPH, causing about 1% of cases. So what is the definition of primary postpartum hemorrhage? Unfortunately, there is no standard definition of PPH that is used in research and in professional guidelines. Some amount of blood loss is normal and expected after childbirth. However, too much blood loss is an emergency that can be life-threatening. Therefore, the question of where to draw the line between normal physiologic blood loss and excessive blood loss, i.e. postpartum hemorrhage, is controversial. Since the 1950s, postpartum hemorrhage after a vaginal birth has traditionally been defined as 500 milliliters or more blood loss within 24 hours of birth, and severe postpartum hemorrhage has been considered 1,000 milliliters or more of blood loss. Until recently, this definition for PPH was applied to all mothers everywhere, regardless of their health status, and regardless of whether or not they suffered any harmful effects from their blood loss after birth. Researchers are now in the process of redefining postpartum hemorrhage, based on research that healthy birthing people are usually unharmed by blood loss up to 1,000 milliliters. For perspective, blood loss around 500 milliliters is similar to a routine blood donation. That's a loss of about 2 cups of whole blood, which is usually well tolerated by healthy people. The blood that is lost after birth is sometimes also diluted with urine and amniotic fluid. In addition, there's an expansion of blood volume that occurs during pregnancy by about 1,250 milliliters that helps protect birthing people against the harmful effects of blood loss after birth. A review by Erickson et al. That included 2 randomized controlled trials of people who did not receive any Pitocin to start or speed up labor found that the average blood loss calculated by weight was just over 500 milliliters among the people who did not get Pitocin after birth, and closer to 400 milliliters among people who received Pitocin. So it's possible that blood loss around 500 milliliters could be considered normal or physiologic blood loss after childbirth. Accordingly, a joint consensus statement of midwifery organizations in the United States defined, quote, results in physiologic blood loss, end quote, as one of the components of normal physiologic childbirth. On the other hand, it's important to consider that individuals vary in when they will experience harm from blood loss. Some people experience signs and symptoms before losing 500 milliliters of blood. and others can lose 1,000 milliliters or more of blood after birth without any clinical side effects. Mothers with anemia, those with low body mass, and those who have decreased blood volume from dehydration or preeclampsia are more likely to feel the effects of losing even just a few hundred milliliters of blood. In light of this new awareness, the American College of Obstetricians and Gynecologists, or ACOG, updated their definition of PPH to account for the fact that the clinical consequences of blood loss vary by individual. They now define postpartum hemorrhage to be a blood loss of 1,000 milliliters or higher with any type of birth, vaginal or cesarean, or any amount of blood loss that is accompanied by signs and symptoms of low blood volume within 24 hours following a vaginal or cesarean birth. Signs and symptoms of low blood volume may include having a fast heartbeat, low blood pressure, fast breathing, low urine output, unhealthy paleness, dizziness, or an altered mental state. However, many of these signs of hemorrhage are very late, indicating a stage 2 or 3 of hemorrhage. Clinicians believe it is unwise to wait that long to initiate intervention. ACOG states that blood loss over 500 milliliters should trigger increased supervision, but does not make the diagnosis of PPH alone, without additional signs and symptoms of decreased blood volume. So how do we know how much blood volume you may have lost? How do care providers assess blood loss? Visually estimating how much blood has been lost is the most common method of estimating blood loss volume after birth. With this method, the care provider looks at the amount of blood lost and tries to estimate its volume. Researchers have consistently found that care providers tend to over or underestimate blood loss volume with their visual estimates. This holds true across provider types and birth settings. Smaller volumes of blood tend to be overestimated, and larger volumes of blood loss tend to be underestimated. So providers might see what they expect to see based on their training about typical blood loss after birth. A more precise method of assessing blood loss volume is using direct blood collection and measurement, often referred to as quantified blood loss. With this method, all of the blood that is lost in the third stage of labor, except the placenta and membranes, is funneled out from under the birthing person's buttocks and into a collection device, such as a bag, a bedpan, or an absorbent pad, where the blood can be measured. One of the key reasons for implementing actual measurement of blood loss is to improve communication between providers. Another reason is that it could lower the risk of implicit bias. It is possible that there is racial bias or racism in postpartum hemorrhage assessment. Poor recognition of a postpartum hemorrhage could delay treatment. In a large study with more than 360,000 participants with postpartum hemorrhage in U.S. hospitals, found that Black women were at the highest risk for severe illness from postpartum hemorrhage, and at 5 times higher risk for death compared to non-Hispanic white women. This study, combined with other research looking at the effects of racism on maternal health, provides support to the concern that implicit bias and racism is driving the increased maternal mortality rates among Black women in the United States. But while quantifying blood loss with measurement is more accurate and it's more objective for assessing blood loss volume, it might not be practical in all birth settings. A Cochrane review by Diaz et al. Found only 2 trials comparing different methods for estimating blood loss after vaginal birth. And right now, there isn't enough evidence to recommend direct measurement of blood loss over visual estimation. In addition to assessing the blood loss volume, care providers also need to assess the speed of blood flow and how well the birthing person is tolerating the blood loss. A review of the research by Hancock et al. In 2015 concluded that these are also important factors in early diagnosis and treatment of postpartum hemorrhage. So how common is primary postpartum hemorrhage? Well, estimates vary widely depending on which definition of PPH is used. Randomized controlled trials have found rates of blood loss greater than 1,000 milliliters ranging from 0.9% to 2.9% when a uterotonic drug is given routinely in the third stage versus 2.4% to 4.8% when a uterotonic is not routinely given in the third stage. In the United States, the rate of PPH greater than 500 milliliters after vaginal birth or 1,000 milliliters after cesarean birth was 3% in a large study of 8.5 million hospital births between 1999 and 2008. This study was published by Kramer et al. In 2013. During the study period of the years 1999 to 2008, the overall rate of PPH stayed around 3%. Now remember, they were using that older definition. However, the rate of severe PPH that led to blood transfusion, surgical removal of the uterus, or surgical repair of the uterus rose from 1.9 cases per 1,000 in 1999 to 4.2 cases per 1,000 in the year 2008. Another study from the Netherlands looked specifically at postpartum hemorrhage greater than 1,000 milliliters among 2.5 million people who gave birth between 2000 and 2013. They found that PPH rose significantly from 4.1% in the year 2000 to 6.4% in the year 2013. In fact, researchers in Australia, Canada, the United Kingdom, and the US have all reported a recent increase in the rate of postpartum hemorrhage, and researchers don't know why. They speculate that the increase in postpartum hemorrhage may be related to more mothers with risk factors for postpartum hemorrhage, more people giving birth after a prior cesarean, more multiple pregnancies, and an increased use of induction, augmentation, and epidurals. However, there is very limited evidence to support these possible explanations. More research is needed on why the rates of severe postpartum hemorrhage are increasing, using the new definition of postpartum hemorrhage, because we do not yet have solid evidence on why this is happening. So what factors increase the risk of postpartum hemorrhage? Well, first, it's important to point out that anyone can experience too much blood loss after birth, even if they have no known risk factors for postpartum hemorrhage. This is why many professional organizations recommend active management with the routine use of Pitocin for everyone, regardless of their individual risk factors for postpartum hemorrhage. However, studies have identified many factors linked to an increased risk of severe postpartum hemorrhage. It's really important for people to discuss these risk factors with their care providers and consider how these risk factors may apply to your unique situation when you're deciding between active and expectant management for the third stage of labor. Some of the risk factors can be known before you give birth, but some can only be known after the birth of the baby. In our signature article on this topic, which is available at evidencebasedbirth.com/third stage, Table 1 is a great visual explanation of the different risk factors for severe postpartum hemorrhage, defined as blood loss greater than or equal to 1,000 milliliters and or blood transfusion, surgical repair, or surgical removal of the uterus. We looked at data from population-based studies in the United States, the Netherlands, Canada, Norway, Israel, and Sweden. And we divided the risk factors between stronger risk factors, moderate risk factors, and weaker risk factors. We also separate them out in terms of whether they can be identified before labor or if they can be identified during labor or with the baby's birth. Stronger risk factors that can be identified before labor include having a condition where the placenta covers all or part of the opening of the cervix and abnormal uterine anatomy from fibroids. Stronger risk factors that can be identified during labor or with the baby's birth include a cervical or high vaginal tear, uterine rupture, or the placenta being manually removed with the care provider's hands because of a long third stage. Moderate risk factors for postpartum hemorrhage that can be identified before labor include having high blood pressure disorders during and or before pregnancy, having given birth 5 or more times, being pregnant with multiples, or having a first-degree relative with a history of postpartum hemorrhage, such as a sister or a mother. Moderate risk factors that can be identified during labor or with the baby's birth include the placenta separating from the uterine wall before birth, uterine infection, giving birth with forceps or vacuum, having a 3rd or 4th degree perineal tear, giving birth by cesarean with or without labor, and having a large baby that weighs greater than 9 pounds 15 ounces. Weaker risk factors that can be identified before labor include prior cesarean or prior uterine surgery, high amniotic fluid levels, age less than 20 or age 35 or older, being a first-time mother, especially if you're an older first-time mother, having a baby in any position other than head first, and giving birth at 42 weeks or greater or preterm. And weaker risk factors that can be identified during labor or with the baby's birth include the use of general anesthesia, use of opiates or an epidural, having a medical induction of labor, having a medical augmentation of labor where drugs are given to speed up labor, having an episiotomy or surgical cut to the vagina during birth, having a baby who weighs greater than 8 pounds 13 ounces. So that kind of concludes the section of this podcast and signature article where we talk about the background on postpartum hemorrhage. Next up, we're going to talk about the evidence on the different types of management of the third stage of labor. Well, first, let's look at randomized controlled trials comparing the traditional active management package to the expectant management package of the third stage of labor. A recent Cochrane review published by Begley et al. In 2019 examined 4 randomized controlled trials with nearly 5,000 people who were assigned to active versus expectant management in hospital settings. It's worth noting that the care providers who attended the births in these studies were more familiar with active management than expectant management. Some of the people in the studies were considered at low risk for bleeding after birth, and some were at higher risk. Many of the people in these studies had their labors induced or augmented with Pitocin. So what did they find? Overall, there was high quality evidence that active management reduced the average amount of blood loss at birth by around 80 milliliters. It's important to note, however, that only one of the 4 studies actually measured blood loss. The rest estimated it visually. And so the other studies are open to mistakes in measurement as well as possible bias from not being blinded to the study groups. In other words, the care providers in these studies were not blinded to which group each person was assigned to. And so they may have assessed blood loss based on their beliefs about who was at greater risk for losing more blood. Since these visual estimations of blood loss can be subjective, the Cochrane reviewers also reported the mother's hemoglobin, if it was less than 9 at 24 to 72 hours after the birth, as kind of a hard outcome related to blood loss. They found that fewer people had anemia after birth with active versus expectant management, 4% versus 7%. This was low quality evidence. However, they point out that the average difference between groups may not be clinically important, as routine blood donation reduces hemoglobin levels by a similar amount without causing bad side effects in healthy people. And these levels may rise again within a few days after birth. The Cochrane reviewers found that active management reduced blood loss greater than 500 milliliters at birth. About 5% of people lost more than 500 milliliters with active management versus 15% of people who received expectant management. This was moderate quality evidence. As far as severe blood loss goes, which is more than 1,000 milliliters at birth, active management also showed benefits. However, the Cochrane authors called this finding, quote, uncertain, because the evidence was considered to be of very low quality. The absolute risk of having a postpartum hemorrhage of more than 1,000 milliliters at birth was 0.9% in people in the active management group versus 2.4% of people with expectant management. And this data came from 3 randomized controlled trials. To put it another way, there would be 1 fewer postpartum hemorrhage with more than 1,000 milliliters after birth for every 66 people who had active management. On a side note, researchers that look at planned home birth in the United States, where expectant management is routine, have found that a similar or slightly higher number of people are estimated to lose more than 500 milliliters of blood. In their studies, it was 15.5%, and greater than 1,000 milliliters of blood. In their studies, it was 4.8%. In the Cochrane review, fewer people assigned to active management in the trials required a blood transfusion, so 1% with active versus 3% with expectant management, and this was low quality evidence. They found no difference in the number of babies admitted to newborn care units or the numbers of babies with jaundice requiring treatment. There was also no evidence that active management changed the rates of needing to remove the placenta manually, and it did not change the average length of the third stage. In addition to the benefits for blood loss prevention, there were some downsides to active management for mothers and babies, and this was considered low quality evidence. People who received active management had an increase in blood pressure, 3% versus 1%. However, this was probably due to ergot containing preparations, not Pitocin. With active management, people were more likely to experience vomiting after the birth, 7% versus 3%. More people had after pains that required pain medication, 5% versus 2%. And there was a higher rate of mothers needing to return to the hospital for bleeding after discharge, 3% versus 1%. The increase in the number of people returning to the hospital with bleeding after they were discharged is concerning. For every 65 people who had active management, 1 returned to the hospital because of bleeding. The authors guessed that the increased risk might have been due to shreds of tissue left behind after cord traction, which is used as part of the active management package. The Cochrane authors looked separately at the risk of severe postpartum hemorrhage in 2 trials with nearly 3,000 people considered to be at low risk for experiencing postpartum hemorrhage. Both of the studies excluded people with a history of hemorrhage, people who had given birth more than 5 times or had anemia during pregnancy or had placental problems, forceps or vacuum use, epidural use, or any medical conditions that can increase the risk of bleeding after birth, such as high blood pressure. All of the mothers in these studies were planning to give birth vaginally to single head-first babies. The Cochrane authors found no evidence that active management lowered the risk of severe hemorrhage of more than 1,000 milliliters in people at low risk for bleeding. So in conclusion, this Cochrane review found both benefits and harms to active management. Active management lowered the risk of severe blood loss and anemia after birth in a group that included both people at lower risk for bleeding and those at higher risk for bleeding. However, it also increased the need for pain medication for after pains and increased the risk of excess bleeding following hospital discharge. It's possible that the benefits of lowering blood loss could be achieved with less harm by making changes to the active management approach. These changes could include using a medication that does not raise blood pressure, such as Pitocin, improving skill or eliminating the step of cord traction, and delaying cord clamping. The Cochrane authors recommend that people who are pregnant be given information on both the potential benefits and harms of active management to support informed choice. Unfortunately, right now, the evidence we have on which management approach lowers the risk of severe blood loss of greater than 1,000 milliliters, which is our new definition of postpartum hemorrhage, is considered very low quality. So it's difficult to draw firm conclusions, especially among people who are at low risk for PPH. The quality of the evidence is higher when they looked at research showing that active management lowers blood loss by around 80 milliliters and the rate of blood loss of greater than 500 milliliters. But these outcomes are not as clinically as important as a reduction in postpartum hemorrhage of greater than 1,000 milliliters. Next, the authors of the Begley et al. Cochrane Review also looked at 4 trials where they looked at active versus mixed management of the third stage of labor. Unfortunately, all of the mixed managements differed, so the researchers were not able to draw firm conclusions on any of the approaches. Out of the 4 trials on mixed management, only 1 was considered to be high quality. That study compared active management, the traditional active management, to a mixed management where people received a placebo of saline instead of Pitocin. The cord was clamped immediately and there was no cord traction. All blood loss was collected and measured. The researchers in this study by Jankston et al. Found that when they compared with mixed management that did not use any uterotonics, there was no Pitocin used, active management with Pitocin reduced blood loss of 1,000 milliliters or more up to 2 hours after birth, 10% versus 17%. Both of these rates are surprisingly high. So this raises the question, are there any randomized controlled trials that compare simply Pitocin versus no Pitocin, regardless of the other parts of the active management package? Well, in 2019, Salati et al. Looked at 9 trials that randomly assigned people to routine Pitocin in the third stage versus no uterotonic drug or a placebo. The intervention in these trials could be considered mixed management because it included Pitocin but varied in the other components of active management. For example, the studies differed in whether or not they used controlled cord traction or immediate cord clamping in the mixed management package. Most of the births took place in freestanding birth centers or hospitals. Like the Cochrane reviewers with Begley et al., the study by Salati in 2019 found that Pitocin did lower the risk of blood loss greater than 500 milliliters and greater than 1,000 milliliters after birth, and they considered this to be low-quality evidence. The absolute risk of blood loss greater than 1,000 milliliters was 2.9% of people with synthetic oxytocin versus 4.8% of people who did not receive Pitocin. They also found moderate quality evidence that Pitocin lowered the use of needing additional medications to treat postpartum hemorrhage. There was no evidence that Pitocin made a difference in the need to remove the placenta manually or the length of the third stage. They also found no difference in the risk of needing a blood transfusion after birth. So that's the information we have from randomized control trials. As I mentioned earlier, the evidence from these trials comes from settings where care providers are more familiar and comfortable with active management rather than expectant management. And labor interventions, including using Pitocin to speed up labor, are extremely common. So researchers have called for more studies to be done in areas where providers are familiar with supporting the physiologic third stage, such as places like the Netherlands or New Zealand, and in settings where routine labor interventions are not the norm. We found 4 retrospective studies where researchers look back in time at birth outcomes in the last 10 years that reported rates of postpartum hemorrhage and the type of management that was used during the third stage. We were looking for studies that reported the rate of postpartum hemorrhage among people who received active management and the rate of postpartum hemorrhage among a similar group of people who had expectant management. Now, these are observational data, not from randomized controlled trials, so the evidence is lower quality. We can't rule out the presence of factors that might have biased the results. For example, if you have a longer labor, That's linked to more postpartum hemorrhage and more use of active management. 2 of these studies examined postpartum hemorrhage by the type of third stage management as their primary outcome. They reported the rate of postpartum hemorrhage greater than 1,000 milliliters among people who were low risk to be 0.5% to 3.4% with expectant management and 2.9% to 9.9% with active management. So in these observational studies, they found no increase in blood loss with expectant management. On the contrary, they found that people who had expectant management had a lower risk of postpartum hemorrhage, and that active management increased the risk of postpartum hemorrhage. Or at least it appeared to, because we can't rule out that other factors might have mediated that relationship. The largest study from these 4 was published by Dixon in 2013 and included more than 32,000 low-risk people in New Zealand who received midwife-led care in a variety of birth settings. About half of the mothers received expectant management and the other half received active management. In addition to seeing higher levels of postpartum hemorrhage with active management, 9.9% of those who had active management had a postpartum hemorrhage of greater than 1,000, compared with 3.4% of those with expectant management. Active management was also linked to more frequent use of manual removal of the placenta, 0.7% versus 0.2%. Also, they found that people who had active management and then treatment for excessive bleeding had more blood loss than those who had expectant management and then treatment. This suggests that the uterotonic drugs such as Pitocin might be more effective when there's been no prior exposure to the Pitocin. The quality of evidence from these observational studies is not as high as randomized controlled trials. Still, these observational studies raise questions about whether the benefits of reduced blood loss seen in randomized trials apply to people who are at low risk for postpartum hemorrhage and who have a skilled provider who is accustomed to providing expectant management after a physiologic birth. So that leads us to the evidence on best practices. And I want to talk about the evidence on best practices to use with expectant management, and then we'll also include the evidence on best practices with active management. In one study published by Begley in 2012, researchers interviewed expert midwives in Ireland and New Zealand about the skills they use for expectant management of the third stage of labor. To be included in the study, the midwives had to use expectant management with at least 30% of their births over the prior 2 years, and they had to have a very low rate of postpartum hemorrhage with their clients. In general, the expert midwives expressed that their role during the third stage of labor was one of, quote, watchful waiting and alert vigilance, end quote. Expectant management was only considered appropriate following an uncomplicated labor without epidural or synthetic Pitocin for induction or augmentation. The interviews revealed that the midwives shared many common beliefs about how to best support the physiologic third stage of labor. I'm going to list some of the important components that these skilled midwives talked about. Carefully observe and listen to the birthing person, paying close attention to behavior or feelings. Watch for other signs of placental separation, which include a normal separation bleed, also described as a single gush followed by a lengthening of the cord. Foster a birth environment that feels warm, calm, quiet, and safe. Encourage mother-baby attachment by facilitating skin-to-skin contact immediately after the birth. Place the baby on the chest in order to encourage it to initiate its own feed, or proactively latch the baby if there is a concern about blood loss. Do not rush to clamp the cord. Use truly upright positions and maternal effort to birth the placenta. Offer the mother food or fluids to replace their energy for the effort required to birth the placenta. Assist with gentle cord traction by giving a little lift or easing down and out if the placenta has already separated and is visible and descended into the vagina. Plan ahead. Discuss the birthing person's risk factors for PPH and their wishes, and prepare in advance for complications. Some researchers argue that the definition of expectant management that was used in prior randomized controlled trials is extremely limited and might as well be described as, quote, not active management. This narrow definition of expectant management leaves out most of the elements of physiologic third stage care that the expert midwives believe are important, and therefore the findings from randomized controlled trials cannot be generalized to midwife-led and community birth settings. The researchers who make this argument, Hastie and Fahy in 2009, have proposed an alternative name and approach for expectant management. They describe as a holistic approach called, quote, psychophysiological third stage care, end quote. Psychophysiological third stage care includes best practices based on scientific theory and midwife expertise. Basically, Hastie and Fahy explain how environmental factors in the birth environment, such as lack of privacy, Bright lights, noise, and the presence of strangers may disrupt the protective hormonal changes that should occur immediately after birth. To optimize someone's psychophysiology after they've given birth, Hastie and Fahey say that the midwife should act as a guardian so that the birthing person and baby can experience an undisturbed third stage. Dr. Sarah Buckley, a New Zealand-trained family physician and researcher in the field, explains that the fight or flight hormones, epinephrine and norepinephrine, also known as catecholamines, can help keep you awake and energized to push in the second stage of labor. However, in the third stage of labor, these levels start to fall, and if you are cold, shivering, worried, or distracted, continuing levels of catecholamines can disrupt the beneficial effects of oxytocin. Babies also require warm skin-to-skin contact to lower their stress hormones and promote nipple-seeking behaviors. Skin-to-skin contact and breastfeeding or chest feeding further increases oxytocin levels in both the birther and the baby. So in summary, when we talk about best practices for expectant management, it's so much more than simply doing nothing or not active management. Providers skilled at expectant management use many techniques to support the birthing person's own naturally produced release of oxytocin. So we've talked about the evidence on best practice to use with expectant management. What about best practices to use with active management? There's several questions we can look at with active management best practices. The first is, which is the better route to use Pitocin in the third stage of labor? Through an intramuscular IM shot or through an intravenous IV injection? It seems there's disagreement between professional organizations about the best route of giving Pitocin in the third stage of labor. Some recommend the injection into a muscle, an IM, as the preferred route, and others recommend both IM and IV injection equally. Recent guidelines from around the world all recommend 10 international units as the dosage for giving Pitocin IM with active management. In other guidelines we reviewed, the recommended dosage for giving Pitocin as an IV bolus over 1 to 2 minutes range from 5 to 10 international units. Although there was a Cochrane review that examined the evidence on IM versus IV Pitocin for active management in the third stage, the quality of evidence was low or very low, and they did not find any differences between IV and IM routes of administration. So we don't have evidence from the Cochrane meta-analysis that one route is preferable to the other. However, 3 randomized controlled trials have taken place in the last couple of years, and all of them found benefits to giving Pitocin by IV instead of an IM shot. The results from those 3 trials, which I talk about in more detail in our article at evidencebasebirth.com/third stage, suggest that giving Pitocin either as an IV bolus pushed over 1 minute or as an IV infusion completed in around 30 minutes may help lower blood loss after birth better than an IM shot among people receiving active management of the third stage. However, there are other factors to consider in deciding which route to use, such as the birth setting, the provider's skill levels, available resources, and the birthing person's preferences. For example, if an IV line is already in place, then giving Pitocin by the IV route might make the most sense, but the IM route might be preferable if there is no IV. The next question about the active management best practices is, when is the best time to give Pitocin in the third stage of labor? There are several different options for timing that providers can choose from when giving Pitocin in the third stage. For example, it can be given with the birth of the baby's front shoulder, immediately after the baby is born but before the cord is clamped, right after the cord is clamped, or immediately after the placenta is birthed. Some care providers base their timing on what they find most practical. One concern we've heard is that giving Pitocin before the placenta has separated from the uterine wall could cause strong contractions that close the cervix, thus trapping the placenta in the uterus. But there is no evidence to support that the timing of giving the Pitocin makes a difference in the risk of having a retained placenta. The uterotonic medication ergot, on the other hand, has been linked to a massive increase in retained placentas. Unlike Pitocin, ergometrine, which is the medication coming from ergot, causes a powerful continuous contraction that quickly closes the cervix, increasing the risk of a trapped placenta. Another issue to consider is that giving Pitocin before clamping the umbilical cord may expose the baby to Pitocin. There is no reported evidence of any harmful effects on the baby from giving Pitocin in the third stage, but some parents may still wish to avoid this exposure. In 2010, Soltani et al. Published a Cochrane review to look at the evidence on the timing of Pitocin in the third stage. They combined the data from 3 trials with nearly 1,700 people who were randomly assigned to receive Pitocin before giving birth to the placenta, that was with the birth of the baby's front shoulder, or immediately after giving birth to the placenta. The researchers did not find any benefits from giving Pitocin before versus after birthing the placenta. There were no differences in blood loss, retained placenta, length of the third stage, changes in hemoglobin, blood transfusion, the use of additional medications, or the rate of low blood pressure. Other than that, there is surprisingly little research on the timing of Pitocin in the third stage. We found one randomized trial from Turkey that was too recent to be in the Cochrane meta-analysis. They looked at 4 different groups: IV given with the birth of the baby's front shoulder, IV Pitocin with the birth of the baby's front shoulder, IV Pitocin immediately after the baby was born, IM Pitocin with the birth of the baby's front shoulder, or IM Pitocin immediately after the baby was born. There were 150 people in each group. They found no differences between groups in terms of blood loss. The authors concluded that they did not find any hard evidence that the route or timing of Pitocin impacted blood loss. Another Cochrane review published in 2013 by McDonald et al. Looked specifically at the timing of umbilical cord clamping and found that waiting to give Pitocin until after delayed cord clamping does not increase the risk of postpartum hemorrhage. They included 15 randomized controlled trials with nearly 4,000 mother-baby pairs assigned to early cord clamping, which was defined as clamping the cord within 60 seconds of the birth, or delayed cord clamping, which was defined as clamping anywhere from after 1 minute of the birth to when the cord stopped pulsating. The researchers concluded that delayed cord clamping offered significant advantages to the baby, including a higher birth weight, increased hemoglobin levels at birth, and increased iron stores in the first several months of life, with no additional risk of postpartum hemorrhage or retained placenta for the mother. The overall rates of jaundice were not different between the groups. Fewer babies assigned to early cord clamping received light therapy for jaundice, 2.7% versus 4.4%. However, the data that found this association came from an unpublished dissertation study that didn't have an objective measurement of jaundice and was not peer-reviewed. A different meta-analysis on cord clamping published in the Journal of the American Medical Association in 2007 by Hutton and Hassan did not include this one questionable study, and they did not find any relationship at all between jaundice and delayed cord clamping. So if you ever hear people talking about delayed cord clamping causing jaundice, that has not been supported by the evidence. In summary, when we look at the timing of giving Pitocin in the third stage, there's currently no evidence showing that the specific timing that you choose influences the rate of postpartum hemorrhage, and waiting to give Pitocin until after delayed cord clamping has not been found to increase the risk of postpartum hemorrhage either. Another option with active management is whether or not to include the use of controlled cord traction. So as I talked in the beginning of this podcast, traditional active management includes giving you a uterotonic to help your uterus contract, clamping the baby's cord early, and then gently pulling on the cord while applying counterpressure to help pull out the placenta. This is called controlled cord traction. The thought is that controlled cord traction helps to shorten the length of the third stage and reduce blood loss. There's also a concern that giving Pitocin might cause strong contractions and lead to a retained placenta if the placenta is not pulled out quickly with controlled cord traction. A Cochrane review of 3 randomized trials evaluated the effects of controlled cord traction on the third stage. This was published by Hoffmeyer et al. In 2015. They measured blood loss instead of relying on subjective estimates, and the Cochrane reviewers considered the evidence to be high quality. When focusing on the participants who were assigned to controlled cord traction versus no controlled cord traction after receiving routine Pitocin, out of 23,000 participants, there was no difference in postpartum hemorrhage of greater than 500 milliliters or postpartum hemorrhage of greater than 1,000 milliliters, blood transfusion rates, or maternal deaths. Controlled cord traction reduced blood loss by about 8 milliliters, which is not clinically significant, and reduced the length of the third stage only by about a minute. Fewer additional rescue uterotonic drugs were used with controlled cord traction. The authors conclude that, quote, women who prefer a less interventional approach to management of the third stage of labor can be reassured that when a uterotonic agent is used, routine use of controlled cord traction can be omitted from the active management package without a significant increase in risk of severe postpartum hemorrhage, end quote. There is no research on the benefits and risks of controlled cord traction when a uterotonic drug is not used. It's important to mention that controlled cord traction requires skill for it to be performed appropriately. It can result in serious complications when it's done incorrectly. If traction is applied before the uterus has contracted enough and without applying effective counterpressure to the uterus can be pulled inside out. This is called a uterine inversion. Cord avulsion or snapping is another potential complication. that occurs in about 3% of births with controlled cord traction. Another intervention that's sometimes used with active management is something called uterine massage. So I did want to talk briefly about that. Uterine massage involves placing a hand on the birthing person's lower abdomen and stimulating the uterus to contract by rubbing and squeezing. Massage is really a misnomer since the forceful rubbing can be quite painful. One Cochrane review by Hoffmeyer et al. Included 2 randomized trials with people who were randomly assigned to receive uterine massage or no massage after birthing the placenta. In one of those randomized trials, they included 200 people who were randomly assigned to uterine massage or no uterine massage after they received active management with routine Pitocin. They found no difference in rates of blood loss greater than 500 milliliters between groups. There were fewer additional uterotonics used to treat heavy bleeding in the uterine massage group. A second and much larger trial assigned 2,000 people to receive Pitocin, uterine massage, or both. The group that received uterine massage alone had the most cases of bleeding greater than 500 milliliters in 30 minutes. When Pitocin was used, they found no additional benefit from uterine massage. There was one more randomized trial that was very large that came out after the Cochrane review. This was published by Chen in 2013. Here, they randomly assigned about 1,200 people to IM oxytocin immediately after the birth of the baby's shoulder, plus 30 minutes of continuous uterine massage. And they assigned the other nearly 1,200 people to Pitocin alone. The uterine massage, in addition to the synthetic Pitocin, did not reduce blood loss compared to using Pitocin alone. In the uterine massage group, 32% of people reported pain. Now, we've heard some care providers say that they give a gentle massage without using any real force with expectant management to help the uterus shrink down after birth. Either they give a gentle massage or they instruct the birthing person on how to massage their own uterus. However, there's no evidence on using uterine massage with expectant management. All of the research we have on uterine massage comes from active management. And as far as active management goes, the largest study in this topic found no benefits to uterine massage when synthetic Pitocin was used. In addition, many people have contacted us at Evidence-Based Birth to tell us that they experienced uterine massage, that it was extremely painful, and some have traumatic memories of this experience. Uterine massage is different from postpartum assessment of fundal tone, which is a recommended practice. To assess fundal tone or tone of the top of the uterus, the care provider places their hand lightly on the top of the uterus to feel whether or not it's contracting regularly. If it's not, they may ask the birthing person to either chest feed or breastfeed the baby or self-perform nipple stimulation to encourage contractions by stimulating the body's own endogenous oxytocin. With all this talk about postpartum hemorrhage, it made us wonder, are there any trainings that healthcare professionals can take to improve outcomes with postpartum hemorrhage? The truth is, care providers can prepare for obstetric emergencies before they occur. The American Academy of Family Physicians, or AAFP, designed a comprehensive evidence-based course called Advanced Life Support in Obstetrics, or ALSO. This is a training to prepare maternity care providers to effectively manage potential emergencies during pregnancy and childbirth, including postpartum hemorrhage. With the ALSO training, learners complete an in-depth online prep portion and then attend a one-day in-person course. The in-person training is focused on hands-on demonstration of skills, as well as team building, and the importance of the team in managing obstetric emergencies. More than 100,000 care providers around the world have taken the ALSO training. In 2011, a study by Sorensen et al. Looked at 1,000 births in Tanzania and compared postpartum hemorrhage outcomes before versus after their healthcare providers completed the ALSO training. After the training, cases of postpartum hemorrhage with a blood loss of 1,000 milliliters or greater was significantly reduced from 9.2% before the training to 4.3% after the training. So completing the ALSO course is an evidence-based way for providers to lower rates of postpartum hemorrhage. In my discussions with healthcare professionals, both OBs and nurses across the United States, I've been surprised to hear how many of them have not taken the ALSO training. And sometimes I wonder why it's not required for this training to be completed in labor and delivery units in the United States. To me, it makes sense that everybody caring for laboring people should have gone through this training. For birth professionals who are not licensed midwives, physicians, or nurses, you could consider taking the Basic Life Support and Obstetrics course, or BLSO course. This is adapted from the ALSO course. It's a good option for people who do not regularly attend births, but want to be proficient in emergency assessment. The BLSO course is also designed to train first responders and emergency personnel, and it's an excellent introduction for students who want to go into the obstetric field. All right, before we get to the conclusions, I just want to briefly tell you about some of the recent practice guidelines on the third stage. The World Health Organization recommends using Pitocin, either IM or IV, with all births during the third stage of labor to prevent postpartum hemorrhage. They consider the use of a uterotonic drug such as Pitocin to be the most important part of the active management package. The World Health Organization recommends that the umbilical cord not be clamped any earlier than is necessary for controlled cord traction, which they say is normally around 3 minutes. The International Confederation of Midwives describes the third stage of labor as a time of adjustment, when the mother is adjusting to the changes that follow birth and the baby is adjusting to life outside the uterus. It is their position that competency in both active and expectant management of the third stage is a basic midwifery competency. The role of the midwife is to provide all of the necessary information and then support the birthing person's informed decision about what they desire for their placental birth. ACOG, or the American College of Obstetricians and Gynecologists, recommends that all birth facilities have guidelines in place for giving routine Pitocin. They recommend Pitocin by IV or IM injection. And they state that it's okay to delay oxytocin until after delayed umbilical cord clamping. The California Maternal Quality Care Collaborative developed the OB Hemorrhage Toolkit in 2015. They support using active management for all birthing people. However, they emphasize that Pitocin is the main component of active management and clearly state that active management should not interfere with delayed cord clamping and that it should not delay skin-to-skin care. The Society of Obstetricians and Gynecologists of Canada recommends offering active management to everyone to reduce postpartum hemorrhage. They recommend IM Pitocin, but state that an IV infusion is an acceptable alternative. The United Kingdom National Institute for Health and Care Excellence, or NICE, defines active management as the routine use of uterotonic drugs, delayed cord clamping and cutting of the cord, and controlled cord traction after signs that the placenta has separated. They recommend active management for everyone, but say that a woman at low risk of postpartum hemorrhage who chooses physiologic management should be supported in their choice. They recommend giving synthetic oxytocin with an IM injection before the cord is clamped and cut. The Association of Ontario Midwives has an excellent, very comprehensive guideline that was published in 2016. They recommend that midwives should identify risk factors for postpartum hemorrhage during pregnancy and birth and discuss these risk factors and options in an informed choice discussion. They state that if the birthing person chooses active management, midwives should use synthetic oxytocin, wait until pulsation stops to clamp and cut the cord, and use controlled cord traction to birth the placenta. Uterine massage is not recommended. If the birthing person chooses expectant management, midwives should watch for signs that the placenta has separated and monitor blood loss. Wait until pulsation stops or the placenta is birthed to clamp and cut the cord. Wait for the placenta to be born with maternal effort or gravity, although skilled midwives may offer controlled cord traction. And encourage immediate skin-to-skin contact with the infant, early breastfeeding or chest feeding, and other measures that may encourage the release of endogenous oxytocin. Uterine massage is not recommended. So wow, that was a lot of research-based information. If you made it all the way to the end of this with me, congratulations on learning so much about the third stage. Now I want to share with you our conclusions about the evidence on the third stage of labor. Essentially, parents today can choose from 3 different types of management of the third stage of labor. There's expectant management, traditional active management, and mixed management. Early cord clamping has traditionally been part of the active management package, but professional organizations around the world now discourage early cord clamping and no longer consider it to be part of an effective active management approach. That's because early cord clamping has been shown in randomized trials to cause harm to infants. Parents can ask their care provider to leave the cord unclamped until it has stopped pulsating, which usually takes at least 5 minutes, regardless of whether or not they're going to use Pitocin in the third stage. During this delayed cord clamping time, the baby should be skin to skin on the birthing parent's abdomen or chest. Another thing we found in our literature review is that rates of postpartum hemorrhage have been on the rise around the world. The U.S. definition for early postpartum hemorrhage now includes blood loss of 1,000 milliliters or more, or any amount of blood loss that is accompanied by signs or symptoms of low blood volume. Postpartum hemorrhage causes more than a quarter of maternal deaths globally, and in the U.S. it is thought to cause about 1 in 10 pregnancy-related deaths. A large study in the U.S. found that the risk of death from postpartum hemorrhage was 5 times higher for Black women compared to white women, highlighting the massive racial injustices in our healthcare system. Good news is that care providers can prepare for obstetric emergencies before they occur. The ALSO course, or Advanced Life Support in Obstetrics, can help lower the risk of people experiencing severe postpartum hemorrhage, and thus it is a life-saving measure to take this course. We strongly encourage care providers to take advantage of the ALSO training when parents are making their decision about which type of management to choose in the third stage. A meta-analysis of randomized trials found that there are both potential benefits and potential harms to active management and expectant management. In a group that included both people at higher risk for postpartum hemorrhage and those at lower risk for postpartum hemorrhage, active management lowered the risk of blood loss greater than 500 milliliters from 15% to 5%, as well as the risk of blood loss greater than 1,000 milliliters from 2.4% down to 0.9%. It also lowered the risk of blood transfusions from 3% to 1% and the risk of anemia after birth from 7% to 4%. These benefits are likely due to the uterotonic alone, not early cord clamping and not controlled cord traction. However, there are downsides to active management. It increases the need for pain medication because of after pains, and it increases the risk of needing to return to the hospital for excess bleeding later on. When researchers look at people who are considered to be at low risk for postpartum hemorrhage, there is no evidence that active management lowers their risk of severe bleeding. The evidence that we have on these randomized trials comes from settings where care providers are more familiar with active management. Observational studies have not shown an increase in blood loss among pregnant people who are at low risk for postpartum hemorrhage who experience expectant management with a skilled provider after a physiologic labor and birth. Researchers have written about best practices for both active management and expectant management. Best practices for active management include using synthetic oxytocin, i.e. Pitocin, as the uterotonic, waiting until pulsation stops to clamp and cut the cord, consider giving Pitocin, IV, rather than IM, and consider controlled cord traction to be optional for skilled providers. Also, uterine massage is not recommended with active management, but you should have postpartum assessment of your fundal tone to identify any problems with the uterus remaining contracted. Best practices for expectant management can better be called psychophysiological care. They include awaiting signs that the placenta has separated and having someone monitor you for excessive blood flow, waiting until pulsation stops to clamp and cut the cord, supporting the birthing person in upright positions as they birth the placenta with pushing or gravity, encouraging immediate skin-to-skin contact and early opportunities to breastfeed or chest feed, fostering a birth space that feels warm, calm, private, and safe, using a postpartum assessment to determine fundal tone, and having a uterotonic drug available to use as treatment if excess bleeding occurs. So now the bottom line. Both modern active management, which is really mixed management, and expectant management, especially psychophysiological care, are reasonable choices for the third stage. The risks and benefits of each approach should be discussed with families so they can make an informed choice about their care. Informed consent discussions should include how your individual risk factors, if you have any, could increase the risk of postpartum hemorrhage, how unplanned interventions and unexpected complications could increase the risk of postpartum hemorrhage and mean changing your plans at the time, and your own values and preferences for this birth. Definitely, early cord clamping is no longer recommended, and parents should be fully supported in their choice if they ask for the cord to remain unclamped until it has turned white and stopped pulsating, which typically takes at least 5 minutes. Informed consent discussions can also include what your birth setting's ability is to provide each type of third stage care. You can take the best practices for expectant management and active management to an appointment with your healthcare provider and talk about how they usually handle the third stage and whether or not their birth setting can best support your desired choice. Thank you so much for listening to this information. This article was a long time in coming. I'd like to thank Anna Bertoni, MPH, our research editor at Evidence-Based Birth, for her tireless work in helping me put this article together. And we're also grateful to those who peer-reviewed our article. Dr. Margaret Buxton of Baby & Co., Dr. Audrey Linden at NYU Roy Myers, nurse midwife Debbie Newton, certified OB nurse Paula Richards, Dr. Nathan Riley, and Dr. Shannon Vogt. And we're also grateful to Kristen Pascucci of Birth Monopoly for helping us with our medical editing. You can find all of the research references as well as more detailed info on all of these studies by going to evidencebasedbirth.com/third stage. Thanks, everyone, and I hope you found this podcast helpful. Bye.